This presentation is entitled Human Exhaled Aerosol Particle Monitoring as an Index of Viral Infectivity. The abstract is meant to be read and does not have a spoken dialogue. John Lidnicki and his associates captured particles from a recently diagnosed individual who, taking the time to drive from the clinic to her home, had a sampling device placed in her car, and the sampling device showed that 71% of the viral particles were identified in the 0.25 to 0.5 micron range. In an effort to find where SARS-CoV-2 virus particles might be found in exhaled breath, Lidnicki and co-workers at the University of Florida in Gainesville placed a Ceutis 5-stage sampler on the sunshield of a Honda vehicle driven by a person just diagnosed with COVID-19. She traveled in the car for 15 minutes, and within 2 hours of her arrival at home, the sampler was retrieved and analyzed. Note that in filter stage D, 0.25 to 0.5 microns, 71% of the genome content was identified in this size range. In a different experiment from that described previously, co-workers of Pallas in Germany identified the particle size distribution in the exhaled breath of a clinically ill patient who was measured with an aerosol spectrometer that determined aerosol size distribution in that exhaled breath. Face masks, which are used in Germany and throughout Europe, are designated as FFP2 for the ability to remove 94% of all particulate, presuming that the most penetrating particle is in the range of 0.3 microns. However, examining a collection of 12 masks showed that of the particles that were removed, a number of the masks were insufficient in their ability to give complete removal of viral particles in a smaller size range. In this panel, the dependence of mask penetration on particle size is measured. To the right is shown the penetration according to EN 149, measuring the removal of particles from the air sampled through the mask, and demonstrates that all 12 masks showed particle size reductions in a less than 6%, greater than 94% removal. On the other hand, smaller particles were less well eliminated from the air stream, and 3 of the masks were found to have a very significant failure in the particle size range of a half micron and below, while all masks demonstrated significant filtration inabilities at particle concentrations near the range of SARS-CoV-2 virus. This discontinuity is demonstrated by overlaying the particle size distribution of COVID-19 patients with the size-specific filtration efficiency of the mask FFP2 that might be used by healthcare workers. It was noted by Weiss and Weiss that the measured percentage of viral load received by the wearer of the mask is greater than currently assumed, and more than 20% of the exhaled aerosols may penetrate the mask by being of a size range which is not specifically selective for those virus particles. To illustrate this point, the earlier slide showing particle size distribution of a clinically ill patient is overlaid with the filtration efficiency measured for these 12 masks, showing that the actual protective effect in the critical area of virus aerosol exposure is far worse than the specified FFP2 class, and results in the possibility that significant portion of viruses that are inhaled by the wearer of an FFP2 mask can be as high as 25% of the viral load in the room air. European mask testing methods are out of date since they utilize procedures that are not size specific. In the United States, the CDC NIOSH test for N95 filtration efficiency utilizes a TSI 8130A device, which uses a simple photometer for upstream and downstream measurements. A better technology would be to employ size-specific filtration efficiency. The conclusion of these investigations show that measurements made with filtering masks should be undertaken in the fraction where most likely viral particles will be located, and individuals who are likely to be exposed to high concentrations of exhaled viral aerosols should wear the most protective equipment, and the testing methodology should use procedures that are clearly more designed to identify particles of small size. Instead of relying on mask filtration efficiency, it is a better strategy to identify individuals who may be super spreaders of viral particles in their exhaled breath. This slide shows two such individuals, one a normal healthy individual with very few viral particles potentially in shed or exhaled particulate fraction, and the other an ill person who releases over 100,000 particles per liter in a size range consistent with that shown by Lednicki as well as shown in the previous slide. In the absence of effective filtration, it is beneficial to identify individuals who are not virus particle spreaders, and thus the detection of exhaled viruses from normal people is a prudent course. This slide shows that healthy persons have reduced particle number when compared to other individuals who are infectious and shedding. The virus concentration in exhaled particles is likely to be high, and the inhalation of filtered air and the exhalation of that air supplemented by particles is the process by which SARS-CoV-2 infection occurs. The method used in the Resp-Aer-Meter is to utilize a filter cartridge through which inhaled air is breathed into the lungs and then expired slowly through a collecting tube into the measuring device. The device, the Resp-Aer-Meter, will collect air at 10 liters per minute warm the air to prevent condensation in the optical cell, and then using white light spectrophotometric methods will count as well as size particles in the range of 145 nanometers up to 4 microns and above. In the first photograph, an individual is seen breathing quietly through a high-efficiency particle filter, resulting in inhaled air being cleaned of room particulates, and the resulting exhaled air in excess of what is vented through the filter is sampled by the optical spectrometer, which warms the air and measures particle size distribution and particle number. The measurement is based on a white light-emitting diode spectrophotometer that is certified for environmental monitoring, and particles as small as 105 nanometers are detected. Using healthy individuals doing a particle size distribution, it is found that individuals vary with particles up to about 1 to 2 microns, and individuals will range from concentrations of under 50 particles per liter to over 1,000 particles per liter in healthy populations. Examining individuals throughout a week, some variation is seen among the exhaled particle numbers, and these may depend on activity level as well as age. We observed among employees at CH Technologies that older individuals, the author included, seemed to have a higher number of particles in their exhaled breath, and there did appear to be differences between males and females. Working populations at CH Technologies were sampled on a daily basis to assure that those individuals arriving at work could be demonstrated to be virus-free and shown to be low-level emitters, if at all, of respiratory particles in the size range most likely to contain virus. Over a series of days, individuals could be surveyed to demonstrate on a continuing basis that no individual came into the building with an excessive viral or particle output, and most often found older individuals, the author included, had higher particle outputs than younger individuals, and males tended to have a greater output than did females. This is merely anecdotal and is not sufficiently well researched to be a provable hypothesis. In the studies conducted by Pallas and clinical associates in Germany, it was found that among 286 healthy subjects, all fell below 3,500 particles per liter. One anomalous outcome was a subject in the clinical study who was diagnosed as being positive for influenza virus when they arrived for a healthy test conducted on a Monday morning and were found to have a significantly elevated particle output. Comparable results were obtained in Germany when, of 286 healthy subjects, all were found to be below 3,500 particles per liter in exhaled air when respiratory measurements were made following inhalation through an effective particulate filter. However, in the time course of this study, a subject was identified who had an elevated level of particles in their exhaled air and were found over a weekend to emit a very significant increase in particles, and this individual was diagnosed by the medical staff as having an influenza, not COVID-19. Among individuals involved in the clinical investigation, it was found that varying persons had differing levels of particle counts per liter of air, with some values in the range of 50, 60, and 70,000 particles per liter, with a temporal rise and fall consistent with the appearance of symptoms at a time when particle number had returned to normal, suggesting that symptoms may be associated with an immune response, which changes the likelihood of particle shedding. Among individuals who are clinically ill, their particle counts are superimposed on their time course during the illness, and it can be seen that elevations appear in time frames subsequent to early low-level detection. And presently, the time course of symptomatology versus particle emission is being investigated. It is clear from the 4 patients that are shown that there is a time course of particle release that may be consistent with immune response, and reduction of particle output indicates an effective immune reaction. From these investigations, it may be concluded that individuals with low or normal particle emissions in their exhale breath present a low risk of infection to others, whereas superspreaders, who may exhale 100 times more particles and up to 125,000 particles per liter, may be at substantial peril at infecting others, period. In fact, these individuals should wear the most effective masks and be counseled to practice quarantine or spatial restrictions with regard to others. It is possible that individuals infected with COVID virus may present as super spreaders before any clinical symptoms occur.